Welcome back to another great Beyond Clean and First Case collaboration event. This one is called PyroTech, Lighting a Fire for Technical Excellence. I'm Melanie Perry from Beyond Clean and your First Case co-host. I'd like to give a special thank you to our event sponsor 3M for supporting today's educational event. Their dedication to your education is what helped make today's event possible. Michelle Lemmons is the operating room clinical educator at Key Surgical. Michelle has over 10 years of healthcare experience and has worked in nearly every area of patient care, including 8 years in nursing. She continues to play an active role in the surgical industry by working with perioperative professionals to share, develop, and implement best practices to improve patient outcomes and reduce healthcare-associated infections. What is electrosurgery? What are the safety concerns associated with this surgical procedure? Today, Michelle will provide a detailed explanation of how electrosurgery works and discuss common complications with AORN and AST recommended guidelines to avoid complications. You'll be glad you tuned in to this discussion. Let's welcome Michelle Lemmons.
Good morning from Minnesota. It's still morning, right? Thank you so much, Melanie, for introducing me. I'm really honored to be here with you all today, and thanks for taking some time for your education this morning. It's a really fun time to be together. So like she said, my name is Michelle Lemmons. I'm the OR clinical educator at Key Surgical, and I am really happy to be here with you talking about electrosurgery. So the title is How Not to Get Burned, Electrosurgery Fundamentals, Function, and Safety. So the objectives today, I'll kind of go through all of these. It looks like a long list, but we're really going to get through all of it painlessly, I hope, right? So first, we're going to define electrosurgery, set that bar standard for what we all know to be true, right? We'll name some individuals who contributed to electrosurgical practice. We're going to discuss the basics of electricity or electrosurgery. We'll explain the difference between monopolar and bipolar instruments, distinguish between electrosurgery and electrocautery. We'll explain the functions of the ESU, the electrosurgical unit, and we'll distinguish the duty cycles of the electrosurgical unit. At the end, we'll cap it all off by discussing, we'll name some complications of electrosurgery, and we'll list ways of how we can, in our practice every day, kind of avoid, prevent, and respond to some of these complications that are associated. So a little disclaimer that we kind of cover in all of our presentations. We do our very best to provide you with the most up-to-date, research-based, guideline-supported information, but it might not cover every single, it definitely won't, right? We know how it is in the hospital or in the OR. It's not going to cover every single specific for your patient, for your specific case, all your policies and procedures. So definitely reference that, but this is a good source of information to kind of reestablish our knowledge base, right? So very first, right out of the gate, we're going to fulfill one of those objectives and define electrosurgery. So electrosurgery is defined as the use of radio frequency alternating current electricity to create heat in cells to cut or coagulate tissue. And it sounds like a mouthful, but these definitions are really important, and we'll define kind of every little piece of this as we go through the presentation and why it's significant to know exactly what it is and exactly how it works. So right now, what we know is that electrosurgery is the most commonly used energy generating device that we use in the operating room. We use many, but electrosurgery is the most common. We know that it's used in about 80% of all surgical procedures. And that equivalent really is about 40 million cases per year that we're using electrosurgery. So you might be thinking, that's great, Michelle. We use it every day. I totally understand what electrosurgery is. But what data has shown us, kind of across the board for all different specialties, is that what we know about electrosurgery, even though we use it all the time, is kind of lacking. So knowledge of how it works and exactly how we get the tissue effects, we don't really have that support. This data was from a study that was published in February of 2020. They interviewed 52 physicians, residents, first assists, people that use electrosurgery in 40 million cases every year. We use it every day. And what they found was shocking. Yes, the pun is intended. But they found that 58% of this population that they studied was actually considered unsafe in their practical knowledge of how electrosurgery works. And the reason I think this is really important is if we don't know exactly how something works, we're not able to respond, troubleshoot, and react and kind of plan ahead in the ways that we need to. So that's how this conversation really came about. We want to make sure that we know every detail of exactly what we're doing in a really practical, applicable way so that we can create a safe environment and respond for our patients. So these first two slides, this is AORN and got a little cut off on this slide. Just another reason, throughout this presentation, we're going to be talking there's a lot of guideline slides. I won't read every single one, but I do want you to be able to go and reference and find this information independently to support a continued conversation. Of course, if you have a question about anything throughout this presentation, please use that Q&A, send me an email, shoot me a message. I would love to hear from you. But in addition to that, I just want you to also know where these resources are, where this information came from. So this first one is from AORN, and it just talks about the ESU is applicable to your job and you should have ongoing education about it. Same AORN, that your facility should have policies and procedures for the use of all energy generating devices and how to use them and use appropriate patient assessment. AST, the same thing, Association of Surgical Technologists. Surgical technologists should complete ongoing education. So it's a part of all of our job descriptions, ongoing education, and using safety principles. So first, what we're going to do is kind of dive into a little bit of the history. How on earth did we ever start using electricity and electrosurgery to treat patient conditions? When I first started researching this topic it was a little over a year ago. It was just so interesting to me how we use things and we never kind of get that background, which can be a little bit fun. So the first, raise your hand, even though I can't see you. Who's ever heard of Benjamin Franklin? I think almost everybody, if not, great person to read about. So first we're going to kind of jump to about 1740. So Benjamin Franklin was really the first person to say electricity can be transferred, right? It's not really generated by moving two things together. It's transferred from one object to another. And then in 1786, we have Luigi Galvani. So this is about 46 years later, almost 50 years. And Luigi Galvani was an Italian physician, biologist, physicist. And he performed an experiment where he took the exposed nerve on one leg of a frog and touched it to the other leg. And that leg kicked, right? It had a reaction. So he showed that we can use electricity. It can be transferred in tissues. And then we have Joseph Riviere. He was using electricity to treat a patient for insomnia and just happened to one day accidentally use his device and touch a wart on the patient's hand. And so kind of as his own little trial, he just kept applying the electricity to this patient's hand every time he came in for treatment, and the wart actually went away, right? It healed. So he was kind of the first one to use this high frequency electrical current to treat a human condition. And then William Bovie. Bovie is a name that we all know very well in the operating room. This is when electrosurgery really made its big break in 1928. And William T. Bovie was a scientist and inventor, and he was the first person to introduce an electrosurgical generator. So we'll talk a little bit about the generator in this presentation, but really that name Bovie really became synonymous with electrosurgery. In fact, we call a lot of things a Bovie pen, Bovie pad. His name is really synonymous with electrosurgery. So to kind of begin us again, right, we're going to start talking about a little bit of electrosurgery basics, and we'll kind of get to the point of why we're coming around to it in just a few slides here. But atoms are the smallest unit of matter. So the smallest things that take up space, right? So they're made up of three particles. We have protons, neutrons, and electrons. Wait for those animations to come on. And electricity is really the presence and movement of matter with a charge, and it's really particularly focused on the movement of electrons. So you can see them kind of moving around there. And this is just a visual for conversation. So the electrosurgery basics that we're going to talk about today, we're going to start this whole presentation with the four basics, right? The movement of the particles, that is used to create heat in cells. So first we're going to start talking about voltage. The next thing we're going to talk about with relation to electrosurgery basics is creating a closed circuit. Then we have current, and then we have heat and how heat is generated. So that's kind of how this first section of the presentation is going to play out. So first, let's talk about voltage. Wait for my slide to go. There we go. Voltage is the force that stimulates the movement of electrons. And this is all coming from the ESU. The ESU is what we use for this. So we're going to talk a little bit more in a few slides about how the ESU works to kind of perform the functions that we need it to. I always like to think of this as like the coffee that gets me up in the morning. It's the force that stimulates the first motion, right? I need my coffee in the morning to really do kind of anything afterwards. And then next we're going to talk about a closed circuit. We're going to create a closed circuit. So a closed circuit is really the path that we want that electrical current to flow. So for electrosurgery, we're going to use an active electrode. This is kind of where, as we talk about electrosurgery in a little while, it's really important to understand we are creating the circuit, right? That perioperative staff is creating the circuit. Any path outside of the circuit other than the one that we create is where we kind of have complications. So we'll talk about that in a little bit. So the first thing that we have with creating our closed circuit, we have our ESU, right? That's our voltage, gets things going. We have our active electrode. Usually this is our instrument, what we're using to apply that electrical current to this patient's body. And then we have our dispersive electrode. Some people call it a return electrode. And this can either be within the instrument itself, which we're going to look at in a second, or it can be a pad that's placed externally on the patient. You guys know exactly what I'm alluding to. So first, when we talk about bipolar instruments, this is what we have when we have the circuit contained within the instrument itself. So if we kind of remember that circle, we have the ESU that's creating our voltage. We apply the current with the active electrode, and it returns really at that same spot. As you can see, that's kind of how we're creating a closed circuit, is using the device. That's why for bipolar instruments, we don't have to use a Bovie pad. A dispersive pad is another word for those. And contrary to that, we have monopolar instruments. So these are those instruments that require a dispersive electrode. And that, if you can think about it in this way, that's why we need that dispersive electrode. We need to create a safe area for that circuit to exit the body and return to complete the circuit. So here we have the active electrode still being our instrument, and that dispersive or return electrode now becomes that pad that's plugged back into the ESU. So next we're going to talk about current. And all of these things kind of seem like, okay, no big deal, but it is significant when we talk about the different types of current that are used, and we'll talk about that some more. So current is the flow of electrical charge. We have direct current. This is electrons going in one direction, and we have alternating current, where they're kind of changing directions. So we'll talk about that. In electrocautery, we're using direct current. We have this all in one direction, and the significance for this is that when we talk about heat in a second, when you're using an electrocautery device, heat is created in the device and then applied to the patient's tissue, versus when we talk about alternating current. And this is what we use for electrosurgery. So you can kind of see that visual here as well. We have that alternating current. And as we go forward in talking about heat, it's great to understand that it's not the device that's being heated up. The heat is actually generated inside the tissues, inside the cells. So why do we really, kind of care about this? Well, if I told you that you used alternating current every single day, some of you already know. You'd be like, yeah, totally. That's our outlets in our home. But then if you kind of pause and consider that, you're like, wait a minute, have I ever been told not to put my finger in an electrical outlet, right? How can we be using this same alternating current to create very precise and controlled tissue effects inside the cells of our body? And so this is a great conversation about frequency, and that's why it matters. So the frequency of our electrical outlets is about 60 hertz. And when we use alternating current for electrosurgery, we're actually using about 500,000 hertz. So we're really turning up the hertz on that. So we talk about that. We'll talk about that a little bit more in a second, but that's kind of why it matters, is that we're really turning up the volume on our hertz And that allows us to create the type of tissue effects that we want. That's why we're using radio frequency alternating current. That's super fast, significantly more than would be in your outlet from home alternating current. So really the reason why we want to turn this up is exactly what we were talking about, like in your home. If you stick your finger in an outlet, you're going to get shocked. So why don't we have our patients on the operative table getting shocked all the time? 500,000 hertz is significantly too fast for our body to respond with muscle depolarization. So we don't have that muscle and nerve stimulation. We're able to generate heat in the cells, which we'll talk about here, without any of kind of the scary stuff, right? That would absolutely be terrifying. So the final thing that we're going to talk about is heat. And we've already touched on this quite a bit. But the tissue effects are the result of heat. So the tissue effects we achieve with the ESU are the result of heat. And it's important to impress, it's a little bit different. The reason why I'm kind of going all in on this electrosurgery versus electrocautery is if you understand the difference, we have electrical current applied to the patient's body versus a heated tool, sort of electrocautery. I like to think of this kind of like as a branding tool. We're not heating a device and applying it to the tissues. We're generating heat in the cells with great precision. So that's why we're kind of talking about this in depth, so that as things come up and as we're thinking through the complications in a few slides, we're able to troubleshoot because we fully understand what's actually happening. So we'll talk about this as well. So heat is created inside the cells. We know, normal body temperature, 98.6, nothing's happening to our cells. Everybody's pretty content and happy. But if we increase the temperature of our cells to between 140 and 190 degrees, things really start changing. The cell wall that's kind of protecting the inside, right, starts to break down, and the cell loses water. It starts to evaporate, causing that cell to shrink. And another thing that can happen at this temperature is that we have proteins in the cell that denature, so they change shape. And then if we increase the temperature in that cell even farther to about 212 degrees, pop, right, we have that cell, the steam, the water in the cell boils, steam builds up until the cell bursts or vaporizes. So by controlling the exact precision, the exact amount of heat that's generated inside the cell, we can control exactly the tissue effect that we get. So the two ways that we're generating heat with electrosurgery are first through resistance. What type of tissue are we going through? We know that our bodies, while it can conduct electrical current, right, we can have that transferred through. Our cells are resistant to that. So they are kind of fighting against the current going through. And this is sort of that scale of how big their fight is, right? How difficult it is. And through that resistance, we generate heat. The second way we generate this heat is through vibration. And that's back to the conversation about alternating current. You have that going back and forth that's very fast, and vibration creates heat inside the cells. So again, to kind of rehash the point I've been saying the whole time, electrosurgery is not electrocautery. One uses direct current, one uses alternating current. One is heat applied to the body. So if I heat up an instrument and apply it, stick my hand on a stove, I can't control with great precision what tissue effects I'm having. I do get a tissue effect that I desire, right? But with electrosurgery, we can really control precisely exactly how much heat we're generating to get the desired tissue effect that we want. So how does the ESU work? How do we kind of control all these things that we're talking about? As we discussed previously, we use alternating current in our homes. And as we know, our ESU is plugged into that, right? So the first major job that the ESU does is it converts output. It converts that electrical current that it's getting from the wall, 60 hertz, into 500,000 hertz. It gets it to that level that we need to use safely. And secondly is power that we can adjust on our ESU. And power is the rate. We're going to think of it as the rate at which work is done. So really power is like an equation that says voltage times current divided by resistance. That's what power is. So we've already discussed that our electrosurgical unit lets us change the voltage and the current depending on where in the body we are performing surgery. We know that the resistance will change, right, depending on what tissue we're going through. And then the size of our electrode can also kind of change that resistance. So a larger electrode, a lot less resistance. That's a big surface area versus a really tiny one. So you might be thinking, what are you even saying? Why are you talking about this? But it's kind of that basic math problem. If I tell you power is equal to 5, you can add any 3 numbers together to get to 5. So when we set the power limits on our ESU, we're really setting a safety limit. So controlling the power setting, as we've all heard, more specifically using the lowest power setting to achieve the desired tissue effect, is associated with significant decreases in complications for electrosurgery. And then finally, the kind of last little piece that our ESU does, that how it works to control, to get the desired tissue effect, is we can modify the duty cycle with this. And the duty cycle is defined as the amount of time that current is flowing through the circuit. So it's also can be called this current output waveform, which we're going to look at an example of each in a second. And the way these are like our settings that we have. We a lot of times cut, coag, and blend, right? We call them our settings. But what exactly is that doing? What's the difference, really? So another way to think about duty cycle is kind of how long work is being done. So we'll see that in a second. We all have a coworker who is kind of always moving, right? They never stop, they never sit down. They're always going, prepared for the next thing, 15 things in advance, right? But then we also have the coworker who, like, every 5 minutes takes a break, sits down, puts one thing in the computer, like kind of is on and off of their work, right? So our ESU allows us to decide how much time work is being done. So let's look at an example here. One second. I talked through them all without clicking forward, so I'm sorry about that. We'll skip through them to get to the good stuff where you can see. Again, AORN guidelines just to support the lowest power. Decreases the risk of complications. Here we are. There we go. So this is kind of how we're going to interpret that graph. It's voltage over time. So here, as long as you can kind of see the bottom there, for me, it's a little bit cut off, but hopefully you guys can see it. So first we're going to talk about cut. And this is that constant current. This is the worker who's always going, always moving, never stop. That's a full current the whole time. So you can see that thing there. And then cut is a non-contact technique. You can see what we call thermal spread. The heat doesn't really generate to the tissues that are on either side. It's really located right there. And how this works is it uses steam envelope, right? So it's not contacting, but that steam is really slicing through, creating the exact tissue effect that we want. The coag setting, here we go. You can kind of see that visual as well. Oops, sorry. So this is kind of that coworker who works for a little while and then takes a break and works and takes a little break. And this current in the duty cycle is only flowing through the circuit about 6% of the time and off 94% of the time. So the voltage is higher for that shortened amount of time to compensate for those current changes. But coag is a contact technique. We're actually applying that electrode right to the tissues. And this heats those cells up between that 140 and 190 degree range that we know kind of desiccation, right, drying, and that protein denaturation occurs. So we're seeing that exact cell response. That off time, kind of on 6%, off for 94%, allows that tissue to cool, and that's where we get that coag effect. And as you can see with this, it does have that thermal spread, that darker pink circle. So right where you're applying the active electrode, but also kind of the tissue surrounding will have a tissue effect. And next we have the blend setting. So this is really a modified cut setting. There we go. So current is still flowing 100% of the time, but there's periods of increased voltage. So it allows for the tissue to be cut while also providing some coagulation as well. You can see kind of that thermal spread as well. So that's part of the big significance for each of our different settings. So here's a visual, kind of some of the different images, some of the different tissue effects that we can achieve by using these different settings. So the cut, continuous, low voltage, it's superior actually for vessel sealing compared to coag. And kind of knowing how they work, knowing what each duty cycle is doing for our voltage on and off time can really help you to understand what's happening in the tissues and why. So other procedure-related variables, we kind of talked about this, the current density, so the size of our electrode is going to change certain things, different tissue effects, right? And then that amount of thermal spread will achieve different tissue effects as well. So now that we know that we have electrosurgery or electricity flowing through a patient's body, we're applying it, we're creating a circuit, we're creating a path for it to follow and be returned. What could possibly go wrong? What do we ever see go wrong? First, we can have dispersive electrode failure, implanted devices, we can have complication with those, insulation failure, coupling issues, we'll talk about, I think, 3, eschar buildup, and then we can have fires in the operating room. So we'll go through these pretty briefly. Please ask questions or kind of put things in the chat box so I can hear from you, what you've seen, what scares you, what don't you understand about what we just covered. I know that's kind of a lot and a little dense, and I'm going really quickly, but I would be happy to talk through any of that with you. So first, we're going to talk about fires. So energy generating devices like our electrosurgical units, right, are considered ignition sources. So what do we do? How do we create a safe environment when we have this ignition source, right? First of all, some of these you've probably all heard, but again, really great to understand why we're hearing those things and kind of moving forward. So if we can, we should use other technologies than monopolar or laser. So as we kind of reflect back on how monopolar devices work, we have a lot longer circuit for it to return. Bipolar instruments, we have the active and return electrode right next to each other, very short distance, a lot more precision, right, and control. Versus monopolar, we have the active electrode, and then somewhere on the body, of course, as close as possible to the surgical site, we have the dispersive electrode. So we kind of have a longer circuit there, and that can lead to a few more complications. The other way we can kind of help prevent or avoid a fire complication is to use water-soluble lubricants near the surgical site, to use moist sponges near the ignition site, prohibit or not allow alcohol-soaked sponges on the surgical field. Of course, alcohol is flammable. Stop or lower oxygen delivery before using an electrosurgical device near the head, face, or neck, which I think we've really seen a huge, really positive change in that over the last few years, where it's a great, very visible, audible dialogue between the surgeon, the tech, and anesthesia to say, all right, I need you to turn it down for this amount of time. This is what I'm doing. So that's been a really, really great change that we've seen. And then finally, create and implement a fire risk assessment and protocol. And who would I be, right, if I didn't say, and train people on it? Let people know where it is, why it is, kind of how it works, and have a lot of visibility there. Again, some guidelines, we'll kind of breeze over these, but just so you know that this is all here, support for you. AORN and AST both are absolutely incredible resources. AORN has a lot of procedures that you can kind of copy or put your own stamp on, right? And AST's guidelines are very approachable, spell everything out in a really approachable way. So the next complications we're going to talk about are coupling complications. And as we've all seen, right, we are very comfortable in this situation. Anybody that works in the operating room has ever done a laparoscopic case, this is very familiar to you. But the way that we can kind of step back and look at it a little bit differently is to think we have multiple instruments on the field, and then we have a really small area of view inside the body. So we've insufflated the abdomen, and now we can see kind of just the tips of those instruments. So we have many people, many instruments, many different people holding these instruments, right? Not just one person, and then a small area of view. So the first complication for coupling that we're going to talk about is direct coupling. And this is the contact of an energized active electrode, the instrument that we're using, right, with any other metal instrument or object in the field. And so why it's important to remember that there's different people holding different instruments. They might not know if they touch, or they might know better, right, if they touch. So that's kind of a conversation that we can have together as a team. Sometimes we do this intentionally when the surgeon says, buzz me, or apply that tip to a clip, right? So we're heating up a metal clip, and then we kind of do a little electrocautery with our electrosurgical device. So this is kind of the importance of that. What happens is now we've created another active electrode. We've energized something else. So you can see it in both of these images. The blue eye is, we can see this. This is in our surgical field. But that red eye is, now we have the active electrode touching a laparoscope, and that laparoscope now is energized and can burn adjacent tissue, right? It can cause a tissue effect in an area we don't want to, and that we can't see, and that we didn't intended. So kind of to support this, AORN says don't activate the ESU until it's in close proximity or in contact with the target tissue for the desired tissue effect. AST says the CST should follow safety principles, and this is kind of that when we do it on purpose, when we do direct coupling on purpose. AST says you probably shouldn't do it, you might have to do it, so here's kind of how to do it safely. They have some really good guidelines for best practice and also a little bit of those realities, right? So the next type of coupling that we have, and coupling, there's two things coming together, is capacitive coupling. So that's the transfer of electrical current from the active electrode through the intact insulation to adjacent or conductive materials. So we see this a lot when we have a metal cannula, a plastic gripper, when we kind of mix media in different ways. And what can happen is then that becomes energized, that's now conducting electrical current. And as you can see, I think that middle picture is really the best. You don't realize that it's now conducting energy, and it's being applied to a tissue where you did not want an effect, especially in abdominal procedures. Of course, we see this happen in the bowel. So AORN, again, supports this. Select these technologies that minimize the risk for capacitive coupling. AST talks about preventing knotting and bending of the cords. We're going to talk about antenna coupling here in just a second. So this is associated with that as well. And antenna coupling. Now, I always like to ask people who has seen this middle picture, all of our cords kind of bound together in a clip, in a metal clip on top of the patient. And what can happen, worst case scenario, right, is that we now have energized, maybe they're patches, right? They have patches on. And so through that material, we have our ESU cord that's conducting electrical current bundled together very tightly with other insulated cords, but they can conduct electrical current. So through that intact insulation, and now underneath the drape in a place that we can't see and the patient can't tell us, we're actually causing burns from an alternate site where that electrical current is leaving the body. So we really, really want to avoid a lot of this. AORN just really goes in depth about taking the risks to decrease antenna coupling, placing the cord, that ESU cord, right, for our device as far as possible or at 90 degrees to other cords. You don't want to bundle it tightly on top of the patient. And then placing those monitor electrodes as far as possible from the surgical site. Same thing with AST, they support exactly the same statement. The next thing we have is insulation failure, and not a funny story, but kind of funny, right? We take pride in things that we're able to do in our jobs, which is so awesome. But insulation, all of our active electrodes that conduct electricity are insulated in order to safely and precisely apply electrical current, right? So what happens with insulation failure, a break in that insulation where we have conduction going through, causes an alternate pathway. It provides an alternate pathway for electrical current to exit from that active electrode. So as we can see here, again, in that top picture, we can't see it. That blue box is our field of view. And outside of the field of view, we have a damaged instrument, damaged insulation, which we can't often see with just the naked eye, although we should be doing that evaluation as well. That's causing a burn here in this instance in the bowel, a place that we didn't intend. So kind of how this happens, we'll talk about in a few slides, but also the way that we think about this, we're going to talk about eschar in a second. We're scraping, we're scratching instruments. An instrument gets dropped on the floor, or just rough handling can damage that insulation. While it's very hardy, it's not it's not free from damage, right? So one of the ways that we can kind of prevent this insulation damage or really work against having these complications is having a great relationship with our sterile processing department and making sure that both of us together understand that 100% of insulated instruments should be evaluated when they go through sterile processing for insulation damage. In the OR, this is totally us, right? Not using metal to clean. When we're scraping, scratching, doing anything, not using metal to clean any of our instruments really can damage that insulation quickly. I had a conversation with a person about eschar, and they're like, eschar doesn't bother me. I just like scrape and scratch it off. Sometimes I use whatever, the back of my knife, and I'm like, well, it's not great for our insulated instruments. That insulation is very close to the active tip that we're using. The handling of the instrument, again, if you're not quick enough to grab it from the surgeon, it gets set, sometimes it can fall off. So really just being careful, having great conversations about why it's important to take good care of our instruments in the operating room. And then visually examining before each use. Yes, we know that we won't be able to see it 100% of the time. Still best to kind of take a look. So AORN supports all of this as well, examining the electrosurgery unit activated instrument for intact insulation before use. And AST, the same thing, supports, surgical techs to be evaluating the instruments. Next, we have the dispersive electrode burn. So if we're recalling kind of how electrosurgery works, we're applying an electrical current to the patient's body, right? And we're creating a safe circuit for this to enter at the place we want the desired tissue effect. And the OR team is creating a safe place for that to exit. So when we use monopolar instruments or other instruments that are not bipolar, right, we have to use a dispersive electrode, bovie pad, whatever you call it at your facility, return electrode, to create that safe exit. And really the intention of these is that safe exit over a large surface area to avoid exactly these complications that we can see in the images. So dispersive electrode burns are patient skin injuries or burns, right, at the dispersive electrode site. So this is a couple just stick in your brain, right, images of the things that can go wrong. So some best practices for dispersive electrode use and placement is to place on the same side as the operative site, place it as close as possible to the surgical site, over a large muscle mass. Again, we want that large surface area, great perfusion. We want that to be the least resistant path for that current, right? We're setting up exactly what we want to happen. Place it on clean, dry skin. Check for uniform contact. No edges are peeling off. It's very stable on the patient's skin. Never ever cut, alter, or fold a dispersive electrode. That's actually one of the questions that they asked those 52 users in that beginning study that we talked about. If you have a pediatric patient, can you cut a dispersive electrode to fit the size of the patient? And some of them said yes, which absolutely not. You should not be cutting, altering, or folding them. Just use the appropriate size for your patient. And then never reposition or reapply. If they come off, whether it's a reusable or a disposable, you need to kind of replace that, get it in the right place, especially for disposable. The stickiness can wear off, and then you can have a complication just like this. And then not placing over metal implants. Again, remembering this is electrical current applied to a patient's body. It will follow any and every path that it can to escape, right, to get out, to keep going. So if we place this over a metal implant, we're really just begging for that electrical current to go through, cause a burn, heat up that metal device inside the body, and then escape through the dispersive electrode. AORN really supports everything we just said. Select the appropriate size for the patient based on the patient's weight and the manufacturer's instructions for use. So using that device as it was intended, as it was created. So then when the surgical procedure demands, this is AST, the use of monopolar electrosurgery, they should follow the safety principles for the proper placement of the patient return electrode. That's the language that they use. Dispersive electrode, patient return electrode, bovie pad, all the same thing. So the next complication we can talk about is complications associated with implanted electronic devices, or IEDs. Precautions should be taken when the patient has any IED to avoid electromagnetic interference. So what can happen, we put magnets sometimes over devices. AORN has some absolutely rich information on that, when and kind of how to do that. Some of the best practices that we have with these devices, these are kind of things that can be intimidating, where you're like, I'm just going to do it because I don't know what the rules are around it. So AORN has great resources. I am happy to provide that to anybody who kind of wants any of that information. But the first thing we should be doing when a patient has any implanted device is consulting the team that manages that implant. AORN, again, supported this year that said, if you can't get a hold of the team, just call the manufacturer. There's usually somebody on the weekend in the off hours that can be there as a resource to answer your questions and help guide so that you have safe care. Patient and family education, kind of telling them, we took these precautions, this is what happened, but just look out for any kind of things that are different from normal. You did have this procedure, we used electrosurgery, so if you kind of notice any differences in your device, have it checked out. So ensuring that function after the procedure, both us as the team, but also the patient, and educating them. Really considering here the placement of that dispersive electrode. We want to create that circuit. We don't want the electrical current to have to go through that device in order to exit the body. So that's why we put as close as possible to the surgical site, on the same side as the surgical site. We really want that to be as small as possible, not going through any device. And finally here, doing that pre-op, intra-op, and post-op skin assessment. We'll kind of look at a picture here in a second, but again, we want to know where the device is. We kind of want to look around it before, during, and after the procedure, doing those assessments. AORN, again, take precautions when they have an IED. One of the things we think about right away is skin, right, and burns and pressure. But the other thing we kind of don't really talk about maybe, or maybe we can now, which is great, is the functionality of that device. If you have electrical current that flows through a device, it might not cause a skin burn or a skin damage, but it might make that device non-functioning, or it might change the settings within that device. So that's why we want to take extra care with any of those devices. And AST just has some very practical advice. When activated, the active electrode should be kept more than an inch or more than a half an inch from an IED, from any implanted device. So finally, kind of our last complication, last but not least, is eschar, or charred tissue residue. I know that everybody who works in the operating room has seen eschar. It's definitely a part of our life, right? And we know that coated single-use devices are not exempt from eschar buildup. We still have that on all of our devices. So we're going to talk about some best practices for that. Keep the tip of the instrument clean at all times. We're wiping between uses. We're taking all those necessary precautions. Clean away from the incision site. We're not wiping anything in. We're just wiping it away. Not remove with metal. That goes right back to our insulation question, insulation conversation, as well as just our instrument integrity. Not using any metal to clean. That eschar is sticky. It's like cleaning burnt chicken off of a pan, or caramel, right? It's actually called tissue caramelization for a reason. Very sticky, very challenging to remove, but we don't want to remove it with metal because we can damage insulation and instruments. We should be monitoring our power settings. eschar actually impedes electrical current. So if you have a surgeon who says, turn up, I need more power, or they're consistently asking, or they're using more than they usually do for that procedure, take a look at your instrument, kind of pause for safety in that instance, because we know that increased power settings are associated with increased patient risks. Finally, you can use a nonstick solution. AORN 2021 updated their guidelines and said you can use an anti-stick phospholipid solution on your devices, coated or uncoated, to prevent that eschar buildup and reduce the number of times you have to clean it off. This is the AORN guideline, supports everything exactly we just said. Cleaning the tip decreases the amount of resistance. Therefore, the active electrode requires less power. So that's monitoring those power settings. Again, AORN guidelines, this was the update in 2021. 2021. I was just reading the 2022 that was coming out. So I've got myself I'm halfway in 2022 already. Maybe everybody is, but an anti-stick phospholipid solution may be used to decrease eschar buildup. And then they have some really high quality evidence that support that use in there. AST really calls it out. I love AST guidelines. They get right to the point. Knife blade should never be used to clean the tip of an active electrode. It can excessively scratch the tip, reducing its functionality, and presents a risk for a sharp accident. AST really says it's the responsibility of the CST, the surgical technologist, to help the surgeon keep the tip clean of eschar, and they go into how that increased eschar can be a fire risk and other complications. They really call out everything we just discussed. So we have covered a lot today. I feel like I've been talking about a mile a minute, but I'm happy to have this conversation with you any other time. We've defined electrosurgery. We've talked about some of the history of it, kind of how it works, explain the difference in monopolar and bipolar instruments, electrosurgery and electrocautery, and we've discussed complications and ways that we can take in our everyday life, in our everyday work, professional life, to reduce these risk of complications. It has been such a pleasure to be here with you. If you want any more presentations, we have a podcast, we have education on demand on your phone, anywhere you are, as well as on our website, keysurgical.com/education. And then the last kind of slide here is just a list of sources. If there's any information that you want or you want more information about, do not hesitate. Let me know. I would love to share any of that with you. I see a couple questions here.
Yeah.
Thanks.
Yes,
Thanks,
there
Melanie.
are a couple in here. Yeah, I've been sitting in the back going, "Oh, this is good. Oh, this is good." But I'm thinking back to my own operating room experience and circulating, and I threw a question in there while you were talking about cut and coag.
Yeah.
But typically, I would always see 60/60 on my settings, and then I had a couple of surgeons who were suddenly jacking it up to 100 or 110.
Yeah.
Is it safe, or is there a safe parameter that it should ideally be set at, or does that exist?
Yeah, that's a really good question, right? I always say that. I feel like I'm like, oh, don't say that. Well, it is a great question though, because what the challenge is, like we saw at that beginning slide, everybody has these different surgeons. There's no standardized education training for surgeons in electrosurgery. Really, they learn they learn by who they learn from, right? And kind of, we don't have that great building block to say, hey, here's how electrosurgery works. Here's how we're going to use it, monitor these settings, right? Nurses get the education of place the dispersive electrode pad here and do these settings like this and monitor the power setting. If it's high, use the lowest that you can. But we don't really get that understanding of what that means or why, or what normal parameters are. We don't really talk about it. Surgeons are learning who they're learning from. 100-100 works for me every time. I always use it like that, 60-60. Surgical technologists, I feel like, are prepared the most in our group with education about the functionality, exactly how electrosurgery works. But again, they're not the ones kind of making that call. So we know that the most classic setting that people use is 30-30. It's just the most popular, right? But there isn't really a cap to answer your question. There's no like, this is safe and this is not. A group called SAGES has incredible videos educating surgeons on exactly how electrosurgery works and having those discussions. But I think it's going to be through these conversations, understanding how it works, doing a little trial, like, well, maybe I can, like so-and-so uses it at 60-60 and gets great tissue results, or so-and-so uses it at 30-30, kind of that transparency and dialogue about what we know and what we don't and where we learned it from, I think is going to lend to a lot of really great parameters, boundaries, and conversations.
I think so. And I think too, it could also, we were talking later about damaged instruments. It could be that we're turning it up really high because our instruments maybe aren't at peak function. And so we keep turning it up higher to make it work. But both sides of that, making sure our instruments are good, and then maybe just using what we need and not having it. I don't know. Sometimes I felt like it was going to like cauterize the air or something before it ever even got to the patient. They had it turned up. But anyway.
I know. Well, then we also know that those high voltages damage our insulation. They damage our instruments. So it's kind of like, which came first, right? Between eschar, high voltages, the chicken or the egg, right? Pick one. So we have a lot of work to do, but I think it's really good work that we can have conversations between a lot of departments.
I think so. Yeah, you have a question.
I do have one, and it's semi-related to a personal experience. it was probably, geez, 20 plus years ago. And the orthopedist, no fault of his own, was employing this new technique with an ortho wand. And it was to shrink down the muscle, or not muscle fibers, the ligaments, to try and, because my shoulder was, loose, popping in and out and everything. And so that was the new, rave in the industry, and tried it on me. It felt almost experimental in some ways, and ended up long-term causing long-term complications because it ended up destroying the proteins and it stretched out even more. So I guess my question to you would be, is where we are now in the industry, do you have some standards, or what level of testing is being done to ensure these procedures are safe, for one, and then are also not on the experimental side and causing long-term complications that may not be foreseen? But, I think there's a number of ways you could coin that or ask that question, but I thought I'd get your insight on it.
Yeah, I think it's so tricky. So related to this, a lot of questions we get are about like residents performing surgery and kind of, is that safe? And so there's always a line in medicine, which we've all experienced, where you have to learn and you have to try things, but you have that opportunity cost, right? It's always going to cost something when we're learning something new. So I think it becomes really professional integrity to say, here is everything that I know about this. Here is exactly my understanding of how this works, and I've confirmed it in this way. And so then I can tell you as a patient, this is what I know, this is my goal, this is how it's supposed to go. Here are some kind of complications that could happen, and having a really, I guess, a well-rounded conversation. The things, personal belief that I have, right, is that we're not great right now in medicine at kind of helping our patient understand potential complications. We're like, here's the goal, here's what we're going to do, it's going to be awesome. Yeah, it's kind of new, like, what's the worst that could happen? But it's almost, we have to help people understand, like, this could legitimately change your life, right? In a really good way. It could work exactly like we want, but here's kind of some of the other things that could happen, the percentages of how they could happen. And I want you to understand that, like, that sort of empathetic conversation to kind of know. So some of that, I think, is just, again, I'm a huge fan of transparency. I'm a huge fan of education. Having those conversations and that professional integrity, know everything you can know. And then at some point you do have to kind of, make a jump, but having that conversation with the patient to say, here's what I know, here's how it works, here's what I've seen, taking a little bit of time to, because every time we walk into a hospital for anything, it has the capacity to change our life in multiple ways, right? And we don't always, I'm a nurse, I've been a nurse now, right, 10 years, or in healthcare for 10 years, and I still don't know all the complications of, you can't, so just having transparent conversations, I guess, and doing your very best to understand how things work. I hope I'm answering your question.
No, I think you are.
Sorry, I feel like I'm tangent.
I think there's also the flip side of the coin too. It's educating the patient and giving them the decision-making power to go one way or the other, but it's also the physician and the nurse teams educating themselves and understanding the full breadth of what they're doing and what they're working with. And, sometimes, like you said, I feel that they're like, oh, this is the new thing, everybody's doing it. But are you educating yourself on, other procedures and cases across the country that may have run into complications, that type of stuff. So, yeah, no, it's...
And assuming understanding. I think we assume a lot in medicine that the patient knows. Well, we're doing your shoulder. How could you not think that, and you're like, well, I didn't. Because I don't think like that. I don't know.
Yep.
Giving them a little bit more.
Yep.
Okay, we have a question about the dispersive electrode pad. When you're working on a patient who has, say, a total hip replacement already and they have implants, is it okay to put the dispersive pad on the thigh muscle of the same side the patient has a hip replacement if it isn't over the implant? So is the pad okay as long as it's not on the implant?
Good question. And again, you want to think, I don't know where the surgery is taking place, right? So you're thinking about we think about this a lot when we talk about like pads for like oh my gosh, what's the word I want? Like a defibrillator, right? Like an AED. Yeah. So we think about that a lot when we're like, okay, we're going to apply this here and it has to exit here. And we want to get our mind around the same thing with our dispersive electrode, right? Where is the surgery taking place? Is it taking place up here? And now my pad's down here. And so it's going to have to go directly through that implant, right? When you think of where is the path of the current going to be going? So thigh muscle is great. We have a large surface area that usually has great intact skin, right? Most people have pretty hardy thighs. Perfect. That's great. That's great to have, but it kind of depends on where the surgery is taking place. And then on top of that, just exactly that conversation, you have to do now that it's electrical current applied to the body, we're creating the circuit, we're creating the entrance and the exit, right, for this current. You have to make your best, the best educated decision that you can. And if you ever question it, do an evaluation. We have that great scale of assessment. If you're worried about it and you put it there and you're like, well, now I heard Michelle's thing and I'm afraid, just kind of peek in the middle of the procedure if you can and say like, yep, great, perfect. Nothing's going on here. There's no patient complications before, during, and after. So that placement is going to depend on where your surgery is taking place, kind of how you're setting up your circuit like that, right? And then maybe that's your only option. And if that's your only option, we know that exists. A question we get a lot is tattoos, because some older tattoos actually have metal in them.
Oh, yeah.
So like, okay, patient has head to toe tattoos. Where do I put this dispersive electrode? And you follow the same guidelines as close as possible to the surgical site, on the same side as the surgical site. And then you do your best, right, to create that safe circuit for the current with the information that you have, and doing assessments if you're concerned about it. Everybody's just doing their best, right? Everybody's just doing their best. So using the knowledge that you have, you can make a pretty powerful choice and then assess for any complications.
Okay, we're getting close to out of time, but I want you to ask your question before I close this out. It's an excellent question to round out this conversation.
Yeah, I guess it's kind of the elephant in the room these days, right? But so, obviously surgical smoke is a huge topic these days. You see it in all the articles, and there's conferences and sessions that are aligned with it and dictated for that topic. But what are some safety measures and common practice you would recommend to minimize the adverse effects and maintain the safety of those that are in the OR?
Yeah. We should all be using smoke evacuation all the time. Don't wait for legislation in your state. Don't wait for somebody to give you a permission slip. There's so much research, it kind of makes you sick, right? In a good and bad way, I guess, but about the exposure of surgical smoke and the complications that people are having. And it can easily be written off. People are like, oh, it's not that big a deal. I've been doing this for 20 years, right? There's people that I know have been smoking cigarettes for 20 years, and we know that is not good, right? You can have these complications. So use smoke evacuation every single case, every single time where surgical smoke is created, any case where surgical smoke is created, right? Any electrosurgical device and other things. And advocate for it. Get education for your team. We have a CE on surgical smoke. It's close to my heart because there's a lot of people in surgery this is going to affect as we learn more and more. Using that, minimizing your amount of time that you're exposed to surgical smoke in the OR. If nobody will do it, right, using an N95, use something that you can eliminate as much as possible your exposure to surgical smoke. And get educated and get involved. A lot of good things going on right now. Yeah.
No, I have to echo
you guys,
the advocate
thank you.
part. Yeah, advocate for that surgical smoke, because if nobody else is going to do it, you need to stand up for yourself at least, but stand up for your patients in your OR and advocate for it. So definitely, I agree with that. But Michelle, thank you. This was so good.
Thank you.
Really was reminded of a lot of things I know I've learned before, but it was a good, refreshing time to learn it again. And it was very helpful. But so thank you just for sharing your insights and solutions for improving the safety of electrosurgery procedures. If any of you have any additional questions you'd like to ask Michelle, her contact information can be found in the speaker bio tool in the lower right of your screen. And there will be a short 15-minute break before the next session. But thank you for joining us today, and we will see you in just a few minutes. Bye-bye.
Thank you.